is some question in between this and my second talk, which is more into segmental neurovascular syndrome. You want me to keep going, and then we can combine the question. So when we talk about the syndrome or segmental neurovascular disease, the concept is coming from the day one that you hear. It's a neural crest, neural plate, the segmentation, distribution pattern, metameric origin of cell, separate migration, and the target, which is arterial lymphatic veins. And in the evolutive nature over time, potential incomplete expression. Make sure that you remember vertebrate embryos with neural crest cell migrated. We are segmented. We are starting from segmented with all these hot genes interfering with our development. And then the surrounding tissues undergo metameric organization in the head, visible in the pharyngeal branchial arch. And then before the closure of neural tube, the dorsal neural crest cell detached and migrated. There is a role of efferent interaction in neural crest migration, as well as the intersegmental vessel branching to feed each segment. So there is also the separate neural crest cell localized defined in the branchial circuit of separate blood vessels to and from the heart. So with all these concepts, that you also have the linkage between during the formation of the region of the head and neck and brain and the heart. So this is the concept of the possibility of having this metameric linkage of the lesion. For example, I think this is Joe Batashaya. He was in Chiang Mai course in year 2000 with us, and then he worked a lot with Pierre and the group to draw this nice diagram, and we keep using this. These metameric diseases are linked between the three main territories of the head and neck and 31 segmental territory of the level below down to the spine. So it seems easier in the spinal level because we still have the segmental seen clearly at that level. So that is called spinal arteriovenous metabolic syndrome. In the cranial part, we call cerebrofacial arteriovenous metabolic syndrome. So the concept of that comes already, and now with the trigger. The trigger is the last possibility of hitting each timing of forming all these vasculature. For example, if the trigger was attacked during the vasculogenesis, for sure it's going to be the earlier the larger, or even the segmental or metameric lesion can be seen, while the later the focal smaller lesion can be seen. So the time of the trigger attack to each of these is very important target to see many things. So we will talk a little bit about these three groups. First, this type of phases. Secondly, arteriovenous, and thirdly, venous. A little bit of names. If you see we start in 1879 Sturge and 92 Weber. So we know the Sturge Weber come from that period of time when they found this correlation between the malformation outside and inside the brain. And then the Chaumet Blanc, in French name, its association, we found the association of area of the brain, retina, and face. While a few years later, White and Mason found the same thing. So this is probably the things are now linked together. While during that time, Stanley Cobbs found some association in the spinal level with the metabolic skin discoloration. And Rachel found in 78 cervical facial intracranial vascular malformation. Lately, in 90s, Frieden made the conclusion of the phase syndrome. So we start with arthrovenous. The cerebrofacial arthrovenous metabolic syndromes will be seen if you see the facial frontal nasal location. You try to figure out that if it's here, the artery that you should inject because the associated intracranial malformation could be there is where it's this hypothalamus, corpus callosum, and apophysis, nose and frontal area, for example. Okay, so there are CAMS2, CAMS3 follow the distribution. For example, the most common form is CAMS2. This is the lateral optic area with optic nerve, retina, chiasm, parietal, occipital lobe. Okay, related with the maxilla malformation area. And CAMS3 is mostly the mandibular auricular area that you can have posterior fossa malformation. And the rest of SAM is easy. Don't forget that you can have overlapping territory. This is example of CAMS1 that you have, frontonasal malformation, and you have this olfactory hypothalamus malformation seen there. This can present with epistaxis because the malformation is located at the region, and you may be able to find this corpus callosum related to this midline nasal frontal malformation over there. Let's talk a little bit. We published together with the team for CAMS2. We dig into which kind of malformation we will be seeing retinal AVM that mostly the presentation are visual deterioration, and it's mostly happened before the age of 18. And optic nerve chiasm AVM is a progressive functional defect. It's autonomous. So we stage that the challenge for this complex anomaly should be caution. You will see we have this chiasmatic malformation and the symptoms of progressive visual loss over the time. We were seeing this malformation along the optic nerve here, around the chiasm, early extent into the region, and then you need to inject maxillary area, internal maxillary and facial malformation area was demonstrated. The classic, I cannot explain, but the classic external carotid aneurysm, which is mostly this plastic large external carotid artery aneurysm, can be found in this group of CAMS. And it's hardly found in other type of disease for external carotid artery aneurysm. Another group that need to be seen is the malformation inside the bone. You have this girl presented with massive bleeding after the extraction of the tooth, and if immediately the CT scan was showing already some of this malformation expanding the bone. And this is internal maxillary injection to see lateral AP views. So the girl was having this asymmetry, this color of the face. You inject internal carotid artery of the same guy, you see the malformation along optic nerve and chiasmatic area where this collateral contribution from the internal carotid artery down to the malformation of the bone. So treatment will be done over there. Mostly we start if for the transarterial, and if not working, we also have the easy, opening of the bone to do direct puncture. You find in the CT scan, you find a natural hole eroded by the lesion, and you have not too difficult time to puncture. And treatment was to stop the bleeding as much as possible. We were able to hook into that and stop the thing. But there are again metabolic lesions that keep on going and expanding and bleeding. So this is a group that we have a trial with the new thing. Even it's not very direct, but sirolimus seem to be affordable in the hospital mostly the time. But at least it's stable for the bleeding. And we are still looking for the better more direct into the malformation, this type of group, rather than to get the crossover inhibitor. This is chemistry. That have a positive mass around the auricular area and a little bit asymmetrical phase. You hook and you see the posterior fossa, you also have the malformation associated with that, and this is chemistry. This is angiogram. You see again the external carotid aneurysm associated with this malformation injected with the auricular and occipital artery, feeding the malformation and the posterior fossa malformation. So we see that this is what we found, that malformation are mostly like a type of finitis. It is rare to see the real fistula associated with this in this group of disease. Sadly, angiogenic activities are a lot. This is 5-year follow-up in this one of the group that do this metabolic lesion and look how they can become double, triple time. We have a chance to do our own case follow-up for 7 years. All the lesion become a little bit, bigger from this to this type of lesion. But if it's not bleeding, we're still not trying to do much of the treatment unless it's painful, it's bleeding, things like that. So we found, as I told you, that this architecture are different from the classic AVM. I guess mostly the cluster of small vessels intervening normal brain. So it's very challenging. And we don't see much of the bleeding intracranially related to AVMs or the CAMs compared to the sporadic AVMs, intracranial AVMs. So if you believe that there are probably some normal tissue in between and it's mostly angiogenic there, I doubt that we should try to touch if there is not much symptoms to go or it's not bleeding. Show you a lot of angiogenic activities. This is CAMS2. It can be coming like that in 4 years' time. Look at the density, the tiny network, which is not possible to go for to find a real direct feeders to the malformation. And clinically, the charismatic AVMs slowly, progressively make the visual loss, but they are compensatory done by contralateral optic nerve function, so mostly there. So the veins, there are spectrum of the CVMS, cerebral venous metabolic syndrome, that I show you already, the facial orbital durosinus malform DBS, carcinoma, also the spectrum of this metabolic syndrome that can be seen, and even it can extend into the inner part of the body. For example, this is the laryngoscope, finding also the malformation extending the mucosa, ipsilateral side. There are some favorite classic one, and there are DVAs over the region. This is same patient all over the classic type. And we describe the same thing. It can be bilateral in this lady figure, and with the same segment somatic mutation response for this type of venous malformation. CVM 1, 2, 3 can be described. It may not be as different from the arteriovenous type, but you can still see if you see this type of the same CVM1, and probably at the same region you can find this type of pericranial at the same time. This we know venous malformation and ipsilateral, a lot of malformation that can occur with her. So this is the territory of CAM2-3. So CVM 1, 2, 3. What we use to describe as cerebral is just one of the type of CVMs. So you people talk a lot about the symptoms of these stage people, and it can be just one type that a patient usually come with epilepsy, mental retardation. So again, picture of CVMS. The classic findings of is the body involvement usually in CVMS2, the hypertrophy of the region, for example, the CVMS2 is maxilla level, so the growth of ipsilateral maxilla or mandible, the gyral cortical calcification related to occlusion of the venous of the gyral crown, and the brain atrophy can be seen, can extend from the facial to the truncal area, and you can find many classic intracranial abnormality related to this syndrome. For example, this boy having this type of the classic finding of this venous, special venous drainage pattern that you can see. Look at this special venous drainage that was found in this child related to the syndrome. Extend down to extremity, ipsilateral can be seen, and this is in the phase 1, 2, 3 level, and extreme down the same patient. You see hypertrophy of the frontal bones, and this type of choroidal enlargement or hypertrophy that can be seen, type of thing. So it's a syndrome that is very interesting. We cannot help much, but to understand that this can be seen. Lastly is the hemangioma. People were trying to see the facial hemangiomas, and they can group into, again, 3 groups. Frontonasal, 1/3, maxillary, 1/3, mandibular area, 1/3. So it's 30% of distribution. So there are correlation between hemangiomas and then the Walker malformation that we used to say that what is the link between that is the female to male ratio and the benign hemangiomas. And the rest, what we can find is the concept between the correlation of the arrangement of cerebrofacial syndrome and the expression along the cardiac area. I told you that we have this PHACES that will go from 1 to 1. Posterior fossa malformation can be 2 types, either what used to be called Danny Walker or this kind of cystic structure or malformation inside the posterior fossa. But there could be a kind of these hemangiomas inside the CP angle posterior fossa related ipsilateral to the orbit or the facial hemangioma. So this can be seen 2 types. This is another example of either hemangiomas at the region or the hypertrophy of one cerebellar hemisphere and the cystic malformation. And this is 2 patients we have correlated with these hemangiomas. Arterial anomalies, interestingly, there are mainly 4 types. Either ipsilateral agenesis of major cervical artery, ipsilateral embryologic persistent, for example, trigeminal hypoglossal pro-atlantal stapler. We can have arterial stenosis, either starting from the internal carotid, the moya pattern of the distal internal carotid, the baseline osmosis agenesis. And lastly, the dolichoectatic type of arterial segment. This is example from the books showing this fusiform aneurysm of this anomaly that is actually the cervical internal carotid agenesis with this hypostabial persistent and having this fusiform interpreter's aneurysm. Another example of this persistent pro-atlantal type 1 and also the fusiform aneurysm of the ascending at the region. So this is all in the case of the PHACES syndrome. And not only that, you can see the bilateral agenesis. For example, this child agenesis of bilateral carotid and vertebral is the only supply to the brain. And you can find this variation of, for example, the basic origin of this ophthalmic artery can be seen. All variation that you learn from the day one can be seen in the phase syndrome. Carl always showed this, that sometimes you didn't notice that an outcome of the artery originate distal to precon. And this is also the variation that can be found in this group. And you can find this trigeminal artery persistent with the fusiform, again fusiform aneurysm forming like a ring here. This is our own case that we have, coarctation of air downstream, and you have this, moya pattern, look like a kinking of the artery all over the intracranial circulation there. And usually for the less supply one, the patient can present it for sure with a stroke in the young. So that will probably the findings. Cardiac abnormality most of the time is aortic coarctation. That can be other type of anomaly. As well as the eye abnormality is not only hemangioma, but all the variation of these, including colobomas, arcus cornea, can be found. The right side aortic arch and the coarctation can be demonstrated. If you look at the sternal angle, it can be a little dimple, or it can be that bad that you have, some internal structure or open up into exposed that is reported in the literatures for this. So this, our own patient is a symptomatic stroke occur. As you see, this is a very bad situation that you don't have you have stenosis, agenesis of the intracranial circulation. So this is the case, probably the only case that we have that we consult together in the multidisciplinary team and try to revascularization that can start with a blowhole or selective surgical bypass with any type of thing. This is the only case that we try to have the baby doing this bypass, and the patient survived for another 4 or 5 years, and with the sepsis, the baby passed away. The last slide would be the conclusion of what we've been talking for is the relationship between vascular target and timing. For metabolic superficial, in the arterial level, you see the mirror aneurysm, for example, and the arterial capillary, you see the phase syndrome, and the venous capillary, you see arteriovenous malformation, CAMS 1, 2, 3. At the end, you see the drosvenous malformation or venous lymphatic for the CVMS. So this is, for example, what you can understand by this, trying to understand what we are talking about this morning. Thank you.